So are you going to be recording? Okay, in addition to that, there's also the.
Yeah. So,
All right, I think we are ready to get started. We still have to let people into the lobby online, manually, it's part of this site. But otherwise, for those who are here and for those who are online, welcome very much. Thanks for joining us today. We have a very special guest who traveled far and hopefully well. And this is Professor David Goldsmith, who gives us the honor of lecturing on his lifetime experience on silica, where he was very instrumental in discovering that silicosis is an occupational disease that can cause cancer and also other diseases. Professor Goldsmith has his PhD in environmental epidemiology from Chapel Hill, North Carolina, and has worked for many, many years at George Washington University, where he has been and still holds faculty appointment, and he's traveling to Vienna, so we are extremely grateful that he takes the time, including his wife Bonnie. We also want to welcome to give us this lecture today. David, please.
Thank you so much. It is indeed a great honor to be here, and I am very grateful. And on behalf of my wife, we are so pleased to have this opportunity. I am delighted, more than I can say, to have so many students with us, and I very much appreciate your interest and appreciate your questions as we move forward. In addition to this lecture being taped for the University of Vienna, it's also going to be taped for the Workplace Health Without Borders. And I only say that because there are some very crazy people on the Eastern time zone of the United States where it's 6 in the morning listening. Maybe I'm putting them back to sleep, I don't know. At any rate, today is June 20th, so this is the summer solstice, and we are in Vienna. I don't know what you usually do when you have the longest day of the year. Nevertheless, it gives me enormous pleasure, and I feel very honored to join you. I do want to say one other thing before I start. I've tried to give you some highlights of the research in this regard. This is by no means the only set of data on some of these questions, and for some of you with a longer interest level, I urge you, please go to the published literature, and if you have questions, feel free to send me an email. I like emails. I especially like emails from students, not so much from emeritus faculty, because if they're asking me a question they don't know, then we're all in trouble. So anyhow, I have listed my email address on this front page, and if you need to phone me, I have also this phone number here. And again, let us go forward and see what we can do. Okay, I do want to thank Dr. Neuberger, who is here in the audience. You all probably do not know, but he and his colleagues were the first group to initiate a prospective epidemiology study of silica-exposed workers from Vienna, starting in the 1950s, but I think that was your predecessor who started that, and you took this forward. You segregated out the workers that were clearly exposed in construction and ceramics and other high silica dust exposures, and you contributed to the IARC, had a review, and contributed a lot to my thinking, and I am so pleased to be in your city to share this presentation with you. I also feel as if I must tell you about two other colleagues. The gentleman on the left is Umberto Safiati. He was the head of the carcinogenesis research branch at the National Cancer Institute in Bethesda, Maryland, but he, as is true for this other individual, had a strong foot in Europe. He kept his colleagues close from Italy, and he went back and forth and also trained younger investigators. The other gentleman is Corbett McDonald. Dr. McDonald is perhaps better known for some of his research on asbestos, but he was also instrumental in heading up several important studies on silica, and he too had a joint appointment. His appointment was in McGill University in Canada. He was also a very well-known British, had a faculty appointment in London. I apologize, not Imperial College. I'm not really sure about that. So, okay, let's talk about this question about crystalline silica. What we know is that exposure to silica, which is this very small particles, produces silicotuberculosis, severe lung disease called cor pulmonale, and multiple cancers. The focus has tended to be on lung cancer, and we know this is a very crude estimate, approximately 300 deaths per year, although it's underestimated in the United States. If we think about this on a worldwide basis, and again, I'm pretty certain that this is an underestimate as well, 2 to 3 million daily workers do in construction and sandblasting and in other activities like mining and metallurgy, ceramics and agriculture, countertop manufacturing. And I think part of the reason why I'm certain that this estimate is low is that it really doesn't include the number of workers from Russia. And this is China, India, the US, South and North America, that kind of thing. And there has been evidence since the mid-1980s that silica leads to increased risk for multiple diseases. And in that sense, it's like smoking and asbestos as what we call in epidemiology a multipotential health hazard. In other words, it doesn't just cause one disease, it causes multiple diseases. And we'll talk about some of the evidence for these other diseases other than lung cancer going forward. So one of my objectives here are to describe the risk looking at lung cancer and other malignancies, lung cancer after silicosis has been diagnosed, lung cancers related to silica exposures in non-smokers, silica and lung cancer amongst women, silicotuberculosis among South African miners, acute silicosis amongst what appears to be in the United States, and I don't really have a good understanding of whether this is an ethnic issue in some of these other countries on countertop workers, but I do think that is something we must pay serious attention to as it is a severe problem that is new on the occupational medicine scene. We need to talk about autoimmune disease and kidney disease. We need to talk about the risk of co-workers pneumoconiosis, that's what CWP is, amongst young US coal miners. And then lastly, I wanted to briefly talk about artisanal gold mining and adults and children. That's also something that we need to pay much more attention to. So we know that agencies such as the ILO, the IRC, the International Agency for Research on Cancer, and in the United States, the Department of Labor, DOL, or OSHA, on the 24th of March in 2016, they issued a new dust standard, and that went from 100 micrograms per cubic meter down to 1/2 of that to 50 micrograms. And in just this year, in 2024, 2 months ago, 2 months ago, The Mine Safety and Health Administration adopted this same standard for mining. So there's a separate standard for mining in America. There was a challenge in the courts, in the US courts, by the silica industry. And in 2017, the DC Court of Appeals agreed with OSHA and rejected all of the industry arguments, and then allowed, even during the time of Trump, for this new rule to go into effect. As of January 16th of 2018, the EU in the European binding and occupational exposure limits set respirable crystalline silica at 0.1 milligrams per cubic meter. And I looked, but I did not see the concern in the EU for silica being a carcinogen. So I am unsure of what the EU rules are for that. That's something some of you may know much better than I. When you look at these other agencies, I want to bring to your attention the fact that in the US, there's this California Proposition 65. There's a national toxicology program, the National Institute for Occupational Safety and Health, the American Thoracic Society, the EU. They all recognize the strength of the evidence based on the evaluation that IARC has done. And again, IARC has looked at this 3 times, and the first time it was considered a 2A carcinogen in the late 1980s. I believe it was in 87, and then subsequently to that, 97, yes, and 2012, it was upped to a type 1 carcinogen. And we'll talk a little bit more about that, but it was also recognized that silica was a cause of autoimmune disease, nephritis and kidney disease, COPD, chronic obstructive pulmonary disease, as well as lung cancer. So we need to keep that in mind. So very briefly, on the clinical side of this question, what is necessary for the diagnosis of chronic or acute silica-related disease? The first is, as you would well imagine, sufficient workplace exposure to silica dust, much better if there is confirming industrial hygiene sampling that shows you how much exposure there is. And the second is that you need to have X-ray evidence, and we will also talk about this going forward a little bit. There has to be a set of severe disease symptoms: shortness of breath, difficulty walking on level ground, bloody sputum, and other symptoms which may include autoimmune problems, and we'll talk about that going forward. There needs to also be, on the clinical side, a ruling out of other causes. Some of these symptoms can come from other exposures, and you need to rule that out before you say that this patient has silica-related disease. And this is why we always say judgment is a factor in terms of looking at this, at each individual case. I put this slide in. It's very busy, my apologies, but I also know there are clinicians in the room and online, and I wanted to share with you that you need to be aware that when silica dust comes into the lung, it doesn't automatically show up as lung cancer, let's say a month later or something like that. There are these steps. Macrophages need to be looked at, interstitial transport of the particles into the lower regions of the respiratory tract. You have to understand whether there's fibrosis that is occurring or not. And in some cases, fibrosis is not necessary. Nevertheless, you're looking at the bottom for this, what I call tissue reaction. Could be coal dust, could be silica, could be granulomas, it could be other kinds of things on the clinical side to keep in mind. So let us now turn to some of the epidemiology studies. And the first one is by Dr. Kyle Steenland. Dr. Steenland has been one of the real towers of strength in this field. He's studied this, he studied miners, in South Dakota. He's studied a lot of different issues, and have a very high opinion of him, and so should you and everyone in the audience. He collected a group of 10 cohort studies when he was stationed at IRC in Lyon, France. And what he did was he was able to show that when you look at a categorical analysis of the lung cancer risk, that it, even if the first time period doesn't show much change, that after a certain period of time, the risk goes up more or less, so that you can see that these categorical analyses show that there is an increased risk based on the degree of exposure. And here also is one of his really brilliant contributions to this whole field. Dr. Steenland and colleagues put together this spline curve, which is the lung cancer rate ratio versus the log of the cumulative exposure with a 15-year lag. And you can see there it's not very much of an increased risk for the first 4, 5, or 6 years, but then after that, it rises quite dramatically, which is a clear indication to me that there's more dust exposure leads to an increased risk of lung cancer. And again, I think it's essential for us to recognize that Steenland's work in this regard has really brought us to focus full bore on how serious a question this is. So there's also been some work somewhat sort of late in being shared with the public health community and occupational medicine community. There's been an evaluation of the German Wisnut miners. These are miners who worked in very, very severe conditions in East Germany from 1946, I believe, until the late 1970s. Many of you in the audience might know this better than I. But then the cohort was followed up until 2003. There are 2 authors that I want you to be aware of. The first is Soji, 2012, and Kreuzer, 2021. They include nearly 60,000 workers with individual exposure information as to what their crystalline silica exposures levels were. They had additional information about confounders like radon and arsenic with a job exposure matrix. And they looked at these and calculated an excess relative risk, which is abbreviated ERR, with 0 presenting the best fit model. And then every one of these showed that for every 10 years of exposure to greater than 10 milligrams per cubic meter leads to an increased risk of about 6%. So as it goes forward, you can see the study of Wisnut miners showed an elevated lung cancer risk of 2.36, stomach cancer showed 1.28, and liver cancer 1.34. All 3 of those are statistically significant. And we'll come back to a couple of these things going forward. So I also wanted to share with you another European study. This is from Cassidy et al., published in 2007. And what they did, this is in focus in the middle, is the odds ratio. For females, they had a greater than doubling of risk, slightly over 2, not statistically significant. Males had a 1.3, and never smokers had a 1.4, and current smokers 1.4, ex-smokers 1.3. And the bottom part shows the cumulative silica exposure, and you can see 1.07, 1.06, so that a greater exposure at the bottom for greater than 200 milligrams per cubic meter produces an odds ratio of 2.1 or 2.08, which is highly statistically significant. There is an additional study of non-smoking lung cancers by Zika et al. In 2006. So up to 8 years of silica exposure gives you an adjusted odds ratio of 1.2. Greater than 8 years, the risk goes up 2.39. And then they've got this frequency index years of the degree of exposure, up only 42 frequently indexed years increases the risk very slightly, 1.1, but greater than 42.1 index years, the risk goes up quite a bit to 2.45. There's an additional study of Hong Kong non-smokers done by Tsi et al. These are silicotics who were non-smokers, and this is an important point. They looked at 132 lung cancer cases and 536 controls from 2004 to 2006, and the adjusted odds ratio was 2.58, which was statistically significant. When they narrowed their focus to the particular type of lung cancer, adenocarcinoma, the risk was up slightly, 2.91, which was also statistically significant. So this is an important study as well because it pulls out the smoking, which is a known confounder for lung cancer, and leaves us only non-smoking silicotics. There have been other studies of patients. I do want to mention early on, there was an initial study by Finkelstein in Canada in 1982, and Westerholm was the first one in 1980. And they both showed an increased risk when studying in a progressive way, in a progressive cohort study, after the diagnosis of silicosis, they had an increased risk. And there have been a group of meta-analyses showing approximate doubling of the lung cancer risk for workers with silicosis. There was also another investigator, Chiyotani, from Japan, who did a very large study, and that was something that we need to be aware of as well. There is epidemiology evidence for the increased risk of skin, lymphatic, GI, and esophageal cancers and kidney cancers amongst workers with a diagnosis of silicosis. And we also know nephritis, and that is kidney disease, has been linked with silica dust exposure and with silicosis. Okay, what about CWP? That's CWP stands for coal workers pneumoconiosis. It's often thought that coal miners are really exposed only to coal dust. And we know that in the earlier studies, let's say in the 1950s, 60s, 70s, and 80s, at least in the United States, that was probably true. But very recently, we have begun to look at coal workers' risk because many of them have lower exposures to coal seams, very thin, but in order to get access to them, they have to dig a lot of overburden, and a lot of that contains silica. So I just wanted to share with you some data on that. There's an investigator, Thomas Skova, 2017, studied coal workers pneumoconiosis patients. They had a lung cancer risk of 1.7, and for non-malignant respiratory disease, an SMR of 2.78. So in this case, coal workers were exposed to coal dust and silica as well. There's also a study from Taiwan by Hung et al. In 2013. They did an incidence study. All cancer had an SIR, standardized incidence ratio, of 1.12, esophageal cancer 1.76, stomach cancer 1.42, liver cancer 1.18, and lung cancer 1.45. And so even though these are really not very high risks, they are all statistically significant. And in this sense, I believe they should be looked at and repeated to see, are any of these types of cancers something that we can confirm along with the lung cancer, which we are pretty certain is linked with silica dust. So I also wanted to share with you another study. Dr. Steenlin was a co-author on this. The first author is a Chinese epidemiologist, Liu, from 2013. They had this very large 44-year follow-up study of 34,000 Chinese tungsten, iron, and ceramic workers with over 11,000 deaths and 546 pulmonary cancers. So overall, a very strong silica gradient with a 25-year lag. You can see what the hazard ratios are. And then what the authors did, which is where I believe they deserve a great deal of credit, they excluded 427 silicosis cases amongst the lung cancers. In other words, they left the lung cancer group with those that did not have silicosis at the time of diagnosis. And then they looked to see, was there any link with cumulative silica dust exposure? And lo and behold, they also found a dose response going from 1 to 1.1 to 1.4 to 1.6 to 1.7. This is a study which straight on negates the argument that people in the industry have made for decades, really, that in order for you to have lung cancer, you must have silicosis. And Liu et al. Said, no, that is definitely not the case. And we need to be aware of that because this is something, as I said, that is an important contribution to the field. Now, I want to share with you a little bit of data from the US. There's something called the Michigan Silicosis Registry, organized by a colleague of mine, Dr. Rosenman, from Michigan State, very well-known clinical investigator. And what he did is that, and these are data from 2004, so it's a little bit out of date. They studied 953 workers. They were all diagnosed with silicosis from 1987 to 2004. They were employed greater than 25 years. 43% were African American and 54% were white. But the silicosis incidence was much greater in Black African Americans than it was in whites. As you can see, 12.6 times 10 to the minus 5 versus 1.8 times 10 to the minus 5 for whites. Thus, African Americans have got 7 times the risk based on data from this Michigan silicosis. 25% of those patients had progressive massive fibrosis and 28% were never smokers. I am a little bit dubious about that percentage because I mean, it was self-reported. We don't know. Nearly 80% of the silicotics had worked in foundries. Some of you may know in the United States, Michigan is a very big steel producing and automobile steel production state. And a lot of them did work in foundries. 25% of them had history of sandblasting. And 54 out of the 953 had worked less than 10 years. And this is something that has me worried because of what we're going to talk about with the countertop workers in a few minutes. The Michigan Sensor Program estimates that it detects only 20% of every 100 true silicosis patients, and nearly 60% of these workers, even though they're clinically diagnosed with silicosis, they've never applied for workers' compensation. So to rely on workers' compensation data as your source for silicosis leads likely to bias. So you just should be aware of it. They also said that relying on X-rays with a 1/0 being a positive X-ray means that they're going to miss 2 out of 3 true cases of silicosis. And there is another investigator who I think originally was from the Czech Republic and went to South Africa and then came back to the States. And all of a sudden, I'm blanking on her name. Oh, dear, dear, dear. I'll come back to that. She has done some excellent research in South Africa and has found more or less the same thing. The reliance on chest X-rays is going to miss a lot of true silicosis cases. They found, that is, Dr. Rosenman found approximately a 1.8 lung cancer relative risk amongst the Michigan silicotics. The woman's name is Eva Hinizdu. My sincere apologies. Our chairman has got a first name, Eva, so I shouldn't have blown that, but nevertheless. Eva Hinizdu has been a strong investigator in this field, and if any of you ever get a chance to meet her, you will agree with me. She's really terrific. This is a study more up to date The author is Makel, published in 2011. This is a study of that same group of silicosis patients we just talked about in Michigan. They did a study from 1985 to 2006, looking at over 1,000 silicosis patients, and they had medical records on 790. What they had also was that 33 of these patients had rheumatoid arthritis after their diagnosis of silicosis. And that gave a prevalence risk of 4.2, and gave a prevalence ratio of 2.26. They had 2 patients with scleroderma, a very high relative risk, only based on 2 patients. So that's clearly needs to be replicated to see if that's an outlier, if it's true. One is systemic lupus, also producing a prevalence ratio of 2.53. 2 had Sjogren's syndrome, producing a reduced risk of 0.42. And 6 had this anti-neutrophil cytoplasm antibody, ANCA vasculitis, producing a very high relative risk of risk ratio of 25.3. So what I'm saying here is that the study of the Michigan Silicosis Registry strongly suggests an autoimmune or systemic disease. And there's this secondary source I wanted to alert you to slightly before then, 1990, a dermatologist from Germany, Haustein, studied the Wisnut miners and did a study from 81 to 88. And they found that 93 out of 120 male scleroderma patients had long-term exposure to silica dust. Keeping in mind, this is, if you will, numerator data only. There's no comparison group here. And 12 patients with scleroderma who also had silicosis. The exposure duration was between 3 and 34 years, and with the interval beginning from the time of exposure, the onset of scleroderma was pretty long, 27 years with a range from 9 to 40. Okay, I also want to briefly touch on some of the non-lung cancers that have been linked with silica dust, and I believe are really in need of additional epidemiology studies to say yes or no, we should include them. That would be esophageal cancer, pharyngeal cancer, large bowel, salivary gland. These are all gastrointestinal malignancies. Lymphatic cancers, leukemia, lymphomas, skin cancers, but I believe that's only been found in studies of workers with silicosis. I have not seen a skin cancer link with those who don't have silicosis. And then we have the kidney cancers as well. So let's also look at some new data from US coal miners. And here are a couple of studies I'm briefly going to try and share with you. Laney did a study in 2010, finding a higher frequency of R-type small opacities during the period 2000 to 2008 for underground coal miners in 3 major regions, Kentucky, West Virginia, and Virginia, compared to the 1980s and 1990s. So this is only from 2000 going forward. They also found a risk 3.8 to 4.4 times the prevalence of pulmonary massive fibrosis comparing to 1990s and 1980s. There was a separate investigation by Blackley in 2016 who discussed this resurgent spike, including silicosis in coal miners. And this is a clear indication that coal mining dust controls are not working, and a call for improved dust standards in the mining field in a general way. There's also a study I want to share with you, which is more up to date. An investigator from NIOSH, the National Institute for Occupational Safety and Health in the US, Noemi Hall, H-A-L-L is her name. She has done a study of the prevalence of pneumoconiosis as well as progressive massive fibrosis. Seems to be on the rise in especially young coal miners that is less than 60 or 65 years old. And contributing factors from her perspective, including mining of these very thin seams of coal, which requires the miners to cut the rock to access it. This is therefore likely to expose the mine workers to coal mine dust, including silica dust, than was the case in the past. And there have been some new changes. I just told you that a couple of months ago, there was a change in the silica dust standard in mining, but it's too early to see if that has reduced the risk that we're talking about. So here is a brief way of us thinking about this from 1995 period, from 95 to 2000 was this percentage of miners, underground coal miners with 25 years of employment in coal mining. And then what's happened since then is there's been a dramatic spike in terms of the percentage with progressive massive fibrosis. And we think that this risk is the result of what we just talked about, thinner seams, more overburden, more silica dust, and less coal exposure. And we need to see if this is true in countries other than the US. So now this is going to bring me to my concern I mentioned earlier about the countertop workers. I found this photograph of this guy who was polishing a countertop. Looks like it might even be a surfboard, but I'm not totally sure that's correct. But the thing that stands out to me and should stand out to you, that's right, he's not wearing any respiratory protection. And it's very hard to tell, of course, in this gray photo, but that's really, really small particle size silica dust. And what we know is that, especially in the countries where these countertop workers have been shown to be at increased risk, that they are exposed to this very fine dust at very high silica concentrations. And to be blunt about it, it needs to be controlled, or else we're going to have a lot more problems, a lot more health problems, a lot more people in their 40s and 50s completely disabled or dead from completely preventable silica-related disease. So here we go. There have been several case reports of employees manufacturing countertops: Israel, Spain, Italy, Australia, China, and the US. The most recent and most worrisome are from California, which we'll talk about in the next slide. And almost all of them are in Spanish-speaking men, and they have got severe acute respiratory and in some cases overlaid their autoimmune disease too, including some workers who are deceased and some workers who have requested lung transplants, which in the US are very expensive and very time consuming and do not have a really good outcome in many regards. Even after the transplant is completed, the worker might still die. And so this is why this is such a crucial issue. I am aware that in the state of California and in Australia, there are now efforts to ban the production of these silica countertops. And from a policy perspective, I understand why that is being put forward, but I'm quite concerned that that is just going to move the production to other places where there is less concern about controlling silica dust. I would welcome a chance to know what kind of a situation there is here in Austria, whether this is a production issue, whether it is a problem, whether it involves immigrant workers or not, because it seems to be the case, at least in the United States. So here is a paper I would strongly recommend you read if you're interested in this countertop issue. It just came out last year. Dr. Fazio is a colleague of, some of you may recognize the name, Dr. Robert Harrison from the University of California at San Francisco. Dr. Fazio has done this superb study. They identified 52 male cases with severe silicosis from 2019 to 2022. The median age was 45, and almost all of them were Latino immigrants. So one apparent white worker, but still quite ill from the same exposure. 10 of these individuals, 19%, were completely uninsured, and 20 or 39% had what we call Medi-Cal insurance. So they had some way of being seen by a doctor and having the insurance cover their costs. But, and 25, nearly half of them presented at the emergency department. And that's where some of the outreach effort was from the colleagues at the University of California, San Francisco, went to the emergency departments to ask them, do you see patients, let's say under the age of 40 or under the age of 50 with this kind of severe lung problems? At diagnosis, nearly 40% had advanced progressive massive fibrosis, was severely or very severely reduced, forced expiratory volume in 1 second. And 19% of the cases were fatal. You can see how much of an issue this is. Nearly 20% were fatal. The age of death was 46 on the average. Think about that, 46 at a time of death. This is very, very, very young, especially in the United States, especially in the 21st century. 11 were referred for lung transplants, 3 underwent a transplant. There was 1 fatality, 7 were declined. And the reason they were declined was because their illness was so advanced, there was no way that a lung transplant would do them any good clinically or for elongation of their lifespan. The work tenure, the median work tenure was 15 years with a range of 10 to 20 years. Nearly half of them reported that there was the use of water suppression for dust migration mitigation. And this is something I don't fully understand. Nearly half of them, 25, continued to work in stone manufacturing after they were diagnosed with silicosis. That suggests to me how severely economically deprived and how reliant their families were on that income. But that's quite an eye-opener. Strongly recommend, if you're interested, read Dr. Fazio's paper that came out last year. So here is a film you can see where the finger is pointing at. This should have been tissue that you could have seen. It's basically gone because of the severity of the acute silicosis. This is one of the patients. He's tethered to oxygen supply. You can also see by the photograph how young he is. And this is something that we in our field really must do everything we can to prevent. So I want to briefly touch on silicosis and silicotuberculosis and want this audience to be aware that this seems to be a major issue, especially in South Africa. And many of you might know, South Africa has got a superb pulmonary medicine community. They are very strongly investigated in preventive medicine, very strongly invested in doing what is necessary with their resources to make sure that workers are treated. And this is something that I think we really do need to pay attention to. There is this, this is a handout to talk about the global TB crisis, the severity of which is the highest in South Africa of any country that I am aware of. And they are trying to alert both the miners, their managers, the corporate world about the severity of this problem. And here is some data from Dr. Ndlovu, it was published in 2018. They investigated the trends of pulmonary tuberculosis in deceased South African miners, both white and black, using this PATHU data, which is this very large data set, pathology data set that they have invested in South Africa for decades, really. The proportions of miners with pulmonary tuberculosis at autopsy increased from about 5% in 1975 to over 27% in 2014. These are in black miners, and from 2%, 2.1% to 5.2% in white miners, with peaks about 2007, respectively. The magnitude and significance of the adjusted odds ratio differed by population groups and calendar periods, but pulmonary tuberculosis was largely associated with a prior diagnosis of silicosis and increasing gold and underground and therefore dusty exposure and year of autopsy. And again, I strongly recommend this if this is an area that's of interest for you. So I found this paper by Howlett et al. From last year, from 2023. They did an assessment that there were approximately 44 million artisanal and small-scale gold miners developed in developing economies like in Africa, in South America, Central America, and in certain parts of Asia. And what they did is that they reviewed the studies looking at silicosis and tuberculosis prevalence and something about whether they were exposed to respirable crystalline silica. And if you look at this, a systematic review enabled them to identify 18 eligible studies that included over 29,000 miners from 10 countries. The silicosis prevalence, again, this is in a group that's very hard to study, these small-scale gold miners that range from 11 to 37%. And my assumption is that these were looking at adults only. Nevertheless, the children are also exposed, and they may have been exposed as young people and then continued to do small-scale gold mining as they became, let's say, older than 16. So you may have had a high silica exposure from a very young age, let's say 10 or 12, something like that. Average median duration of mining was less than 6 years. Tuberculosis prevalence was high, and they had microbiologically confirmed cases range from 1.8 to 6%, and clinical disease from 3 to 17. The average respirable crystalline silica intensity was very high, and respiratory symptoms were very common amongst this group that Howlett et al. Had studied. This is an area that really does today need a serious look. It needs to find a way to transmit what we know to these small-scale gold miners so that they can do something, whether they can wear a mask or use water methods of some sort to keep the dust under control. Because in the absence of that, we're going to continue to see this, especially given the high gold values for an ounce of gold. So there's also this paper by Lee et al. From 2021. They looked at 13 occupational cancers and 3 leading risk factors for cancer burden based on the global burden of disease were asbestos, silica, and diesel engine exhaust. For most occupational cancers, the greatest attributable cancer outcome was for lung cancer, tracheobronchial and lung cancer, which accounted for nearly 90% of the workplace cancer deaths. In 1990, silica was the leading occupational cancer in East Asia, and in Central Asia, it was also true. However, by 2017, silica was the leading cancer only in East Asia, rather than in other parts of the world. The other point that I do want to say is that a lot of cancer and non-cancer is coming about because of past silica dust exposure, but we're not able to attribute that because we don't have good work histories and good industrial hygiene to bank on. So let's ask, what is the synthesis of the current cancer evidence? So IRC's evaluation in 1997 and 2012 has been backed up by studies confirming the lung cancer risk, including studies of women, co-workers, pneumoconiosis patients, and non-smokers. There's strong and consistent evidence of silicosis patients having a 2+ risk for pulmonary cancer with other kinds of tumor sites as well. And here are some of them: stomach, gastrointestinal malignancies, esophageal cancer, you can see this list. Large bowel salivary gland. There's also a smaller amount of evidence for lymphatic cancers, for skin cancers and kidney cancers. Those bottom three are areas I think that really do need additional, really bright epidemiology studies to confirm whether or not past exposures to silica dust are increasing the risk of these cancers. Okay. I also wanted to share with you something else. I mentioned this autoimmune disease, including scleroderma, rheumatoid arthritis. They've been linked with silica exposure, but they haven't really been investigated in the same sense and into the same depth as the cancers and chronic respiratory disease. Especially for South African silicotics, both black and white miners have got an increased risk of tuberculosis. Young coal miners in the US have an increased risk of silicosis and coal workers pneumoconiosis. There's this emerging evidence about artisanal gold miners having excess silicosis and TB. And lastly, this very worrisome, in the US Hispanics, but in many other countries, a concern about countertop workers with very high silica have severe acute silicosis and some autoimmune disease, including deaths and lung transplants. And this is, from my perspective, a clarion call for us in public health to make our communities much more aware of the seriousness about this issue. So I tried to think a little bit from the student's perspective, where could I possibly find a way to contribute to this intellectual community issue? And here are at least some ideas that I think are worth looking at. We need to look at interaction studies between silica and diesel, between silica and polycyclic aromatic hydrocarbons, PAHs, between silica and mercury with regards to artisanal mining. Obviously, silica exposure and smoking, it's been out there. The question really is, we've seen a decline in adult smoking, but is this in fact true for workers who have high silica dust exposure or not? And if the answer is no, there hasn't been much change, then we need to try and figure out a way to do two things. One is predict what kinds of cancer issues are going to be, let's say in 2040 or 2045. We need to also figure out how to do a better job of encouraging silica workers to stop smoking if we can. We need to think about silica dust exposure. There's these countertop production chemicals, phthalates, I think is an area the interaction needs to be examined. We need to think about silica and coal dust as combined risk factors. We need to think about silica dust and radiation. And we need to think about fracking, which as far as I'm aware, has a very, very high level of silica, but I am unaware of any diseases, whether it's cancer or respiratory disease, amongst fracking workers. So in conclusion, we know that patients with coal workers, pneumoconiosis, and silicosis are at increased risk for tuberculosis, autoimmune diseases, and lung and other cancers. But as I said, we need more studies in many regards. And perhaps we need to find additional data sets where we've got larger numbers, especially important when you're looking at some of these rarer illnesses. We need additional morbidity and mortality studies of countertop workers, of coal workers, pneumoconiosis patients, artisanal miners, to try and see if we can get a better exposure disease linkage put together in these regards. We've got many in the traditional industries where we've got better industrial hygiene, but we need to expand that skill level out to other activities that we just talked about. Now, I wanted to sort of pose a question to my clinical colleagues in the pathology field. Are there any data that would tend to suggest surface chemistry or surface characteristics that would distinguish silica-exposed lung cancers or silicosis and lung cancer from what I call garden variety, which would mostly be smoking lung cancers? are there anything that might distinguish those types of lung cancers one from the other? And if the answer would be yes, that might also give us an early lead as to how to intervene and prevent those patients from getting cancers if we know what the cell types are, what the genetic types are. This is an area I think that should be looked at. Agencies need to, like NIOSH and OSHA, they need to be supportive of studies related to silica exposed workers. And there need to be studies in places like South America and in Africa where a lot of silica exposure in industry is going on now, but for which we don't have very good epidemiology data. And then lastly, we need to have, if you will, a corporate buy-in on prevention efforts. The people who are making the money off of the production of these materials, they need to play a much stronger role in prevention than they have done so far. So let's go to the next one. Uh-oh. Looks like it.
Yeah. Is this your last slide, David?
No, I've got one more. No.
There.
Oh, thank you. So I did want to leave you with something from a colleague, Dr. Hoy, who's an Australian occupational physician. And this is from 2022. He wants us to know silicosis is not a disease of the past. It is irreversible fibrotic disease, which is linked with exposure to respirable crystalline silica dust. There are over 20,000 incident cases of silicosis identified in 2017, and I'm of the opinion that's a vast underestimate of the worldwide silicosis burden. There are many insecure workers, immigrants, and workers in small businesses who don't feel that they have a voice. And when they do seek care, it's at a very late stage. And we need to cut that time in half. And hazardous respirable crystalline silica occurs in a wide variety of settings, and they receive less attention than, for example, workers in construction. And the recent outbreaks of silicosis related to domestic kitchen benchtops are really a clarion call to us to look outside our comfort zones to see if there are other industrial sources of silica that we need to pay attention to. And Dr. Hoy mentions nanotechnology and fracking as two areas that need further investigation. So despite countries dealing with these issues, there is an absence of sustained global public health response, including a lack of consensus of what the exposure limit should be. And in this sense, global elimination of silicosis must continue to be our goal in public health and in preventive medicine. So let's see if yes, we've come to the end. I want to thank you all for your attention and for the wonderful hospitality that has been given to myself and to my wife, my beautiful wife, Bonnie, who has put up with me more than she can ever know. If there are questions, I'd be very happy to answer them. I'm not sure about questions from online, but we can certainly try our best. Thank you all.
So I'm sure there are some questions. If I may start off, David, with one particular question that came to my mind listening to you, because there is a lot of talking about lung cancer screening these days.
Yeah.
And I wonder whether it is now across the city process for workers that could be a target group.
Your question implies a great deal of brilliance. The question I am aware of is that there hasn't been lung cancer screening that's been targeted to silica workers, but there should be. There is no question that there is an increased risk, whether the worker has silicosis or not. And in the absence of not having silicosis, there's still a reason to be concerned about an increased risk of lung cancer.
Right, as you have shown beautifully in the talk.
Yeah.
Basically,
It's not only silicosis, that's correct. But yeah, I mean, I think that's an excellent idea. And it's clear we've got the resources in place to undertake that, and we should do it. We should do it.
yes,
Yes. I wanted to ask, usually acidify is taken as a separate entity, or if, for example, if you are combining it to other elements, could it, for example, reduce the effect? So this would be like a solution instead of banning.
Mhm. I understood your question. Could there be a way of mixing silica with other hazardous materials and reduce the risk? I think the answer that I'm aware of only is that if you use water-based methods to increase the capture of this very high biologically active material, small particle sizes, that does lower the risk. But I don't know, based on the data from the University of California at San Francisco, Dr. Fazio, she indicated that there was this relatively high proportion that used water as a means of controlling dust. In spite of that, the workers still have silicosis. Perhaps their risk may have come after the water was introduced. We don't really know that. But that is a very, very good question. I am not aware of other materials.
Yes, advantageous for example, we track the effect of silica once and
Yeah.
very like vitamin D or something.
yes.
Yeah, there was maybe 25 years ago, I think, a Chinese medicine, and I believe I got this right, called Tedron, that was suggested as a means to control silica dust and silicosis, but I do not think there's any supportive evidence yet that you can pre-treat medically to lower the risk. But I would welcome that if something like that appears.
Maybe it's not a very important question, but you mentioned skin cancer.
Yeah.
And I just wonder, is this the skin that's exposed to the dust from the outside? And what sort of skin cancer would it be? Is it, yeah,
And I believe that what we're talking about is not it's malignant melanoma, that's the increased risk. But why, I am confused by that too.
maybe.
You know, the fact that it's in the air and gets on your skin, well, that's one thing, but you know, you take a shower, the risk goes away, it's not being it's not being inhaled like in the lung. I don't know, but that is also an area of research that I think is ripe for some new ideas and new studies, but that's a very good question.
Yeah, extend maybe if outdoor workers that are exposed to silicosis more in that that's why possibly. But I wanted to extend those palace thought. Has it been shown that, let's say, in countries where there's a lot of humidity, which probably brings down the silico dust? I would imagine that the risks are lower there for workers exposed to silico.
Really, we need to do an epidemiology investigation, you and I, and we'll find out. But I think that, I'm serious, I don't know the answer to that. But I do think that's really worth looking at for just what you articulated, that with higher airborne water levels, there should be a reduction in terms of the severity of the inhaled respirable dust. And if so, the risk should be lower than in countries that are drier, like you said. And that's, wow, that's a big, I like that idea a lot. So we've got to write a grant together.
I want to thank you for this magnificent overview of the global situation, and that silicosis is not a disease of the past, but because you asked in Austria, we did not see acute cases of silicosis anymore since the prevention work, exposure and early medical diagnosis, systematic screening in workers exposed and so on. And the last heavy contributions have come from tunnel workers, from granite industry in Upper Austria, but not as you showed us. I've seen actually one case, just the X-ray we have a hospital in Styria which is specialized on silicosis, and they have shown me an acute case, also such a young case, but he was from China.
He was from China.
So that's just to clarify this.
Right.
But another question is the lung cancer, and I think there are different mechanisms involved. It's interesting, you visit us on a day where there is Sahara dust in the air, and I always wondered why the old Sahara dust does not produce silicosis. But nevertheless, if you inhale insoluble mineral dusts, non-fibrous mineral dusts over decades, which is usually done by the general population, and you can have, with the long latencies, you can see effects of even small doses. And then I wonder if it is still correct to use only milligram per cubic meter, but if we shouldn't look also at particle number concentrations, and also on surface characteristics for, of course, the surface in general, lime deposited surface area, but also on surface chemistry, as you indicated. But I wonder if there are any new studies on this.
Yes, let me share with you and the audience a very recent study. I'm almost sure that it was published this year in 2024. And I do not have the authors' names, but there's a group of investigators who have been working with returning US military personnel from Iraq and Afghanistan, who have been exposed to silica in sandstorms and in general have a much higher ambient silica levels than we would have here, for example, in Vienna or in the United States. And they have done some autopsy studies that show, in fact, that these military personnel have got very small micro nodules that seem to have come from their time in the military because they have no other sources in their work histories or in their prior to joining the military, that kind of thing, that would explain that. And I promise I will find the reference and I'll send it to you if you'll make sure that you give me your email address, because I've been using the one at the university, which is not working. But yes, I mean, but what you've asked is a very important point. And we also have seen, in a certain sense, that mostly Spanish-speaking farm workers in the United States who migrate and especially are involved in harvesting crops where there's very dry temperatures, who have very high soil exposures to silica dust, they have a similar kind of an issue. And that's been demonstrated by my old colleague, Dr. Mark Schenker from the University of California, Davis, who examined the lungs of farm worker patients who had died in automobile crashes. And he went to look to see if they had any evidence of just what you're asking for, even though they died, in car crashes. When they did autopsies and they looked at the lung, they found similar kinds of situations. There was a very early paper by Dr. Jerry Abraham on farm workers that suggested something similar too, but that's from the 1970s, if I'm not mistaken. So,
We have one outline question, and then I'm probably starting to look at your time.
yeah, I know that.
But let's just take a look at this by Michael. He asked, he mentioned that it seems that some of the measures taken do not really work. Do we know anything about the difference between workers in the past, suppression, etc., and workers without?
We do know that in certain cases, that wearing dual cartridge respirators, which is the type of respirator covers the nose and mouth, and it's got dual cartridges, that is effective. We know, for example, that dual cartridge respirators around for workers in 9/11 in New York showed just what Michael asked about, and it is effective as a means to prevent the inhalation of silica dust into the lung. We assume that the use of wet methods has a similar benefit, but I don't think it's been as well characterized as it should be, and that's an important point for sure. So, at any rate, thank you for the question.
We're coming to an end, and before we applaud you for the brilliant lecture, we have a small token of appreciation from Austria.
Oh, look at this.
That's a cool.
Oh, fantastic.
Thankful for your lecture. Thank you, David.
Thank you all. Thank you, especially to you students for coming. My pleasure, my pleasure. Thank you so much.
Thank you all for staying. So now we need to stop the recording.
Yeah.
So that we can, okay? We can move on.